Hello, this is Dr. Joe Moscato in one of a series of nursing slideshows. And this one's about communication, specifically communication from nurses to physicians, some vice versa, and how can we make it better. First, let's start with phone calls, because I found that these create some of the most significant frustrations for both doctors and nurses. The nurses say, why don't they make this clear? Why are they so crabby? And the doctors are thinking, why are they bothering me? Why don't they know what's going on? Now, what you have to know when you make a phone call and what you have to be able to tell the physician, especially if this is not that physician's patient and therefore really doesn't necessarily know this patient, is what is the patient's diagnosis and what's the general status of the disease? And why did this patient come in the hospital? These are very important. And you need to be able to say this person has metastatic colon carcinoma and came in for a potential bowel obstruction, for example. And then you have to be very clear about why you are calling. Are you calling for clarification of an order, a change in the condition of the patient, an abnormal lab test, or something else? Now, when you make a phone call, you want to know what is your assessment of the problem and what you think should be done and what you'd like the doctor to do. Now, you don't necessarily have to voice this, but you certainly should have this idea in your head before you make the phone call so you can be sure that you actually get your questions answered. So, what you have to know first of all is you need to know the diagnosis on all the patients you're covering. And you have to have an understanding of where that patient stands in the treatment. Is this a new diagnosis? The patient just came in the hospital, never had this cancer before, is being evaluated, is in the midst of treatment, and if so, what day of chemotherapy is the patient on? Or is the patient just being palliated in comfort care? So these are things you have to know. You can get this from progress notes, history and physical, and a lot of times we'll place office notes in the chart which will have a course of the illness of this patient and some notes also. So you'd like to have a good idea of what's going on. Now, I would look at this and especially look at the diagnosis and treatments and the impression and the plan. And this will be in the initial history and physical, but also will be in daily progress notes for the most part, and they're very useful to look at. If they're not printed, they're in Fido, but most of the time, as soon as they're dictated and in the system, they print. And use this to build your knowledge base of cancer and its treatments also. So I think you could use this as a teaching tool. Now, why was the patient admitted? Please be clear about this. This is helpful. Was the patient admitted for infection, for bleeding, for pain, for nausea, for instance, for chemotherapy itself, or other reasons? And what's already been done for this problem that you're calling about? If it's a fever, please know the fever curve for the last several days. Please consult the MD review and MTech for this or the graphics in the chart. This is really frustrating for the physician if you call with a temperature, for instance, of 102 and you have no idea if the temperature yesterday was 103 and it's coming down or if it was 99 and going up. And if it's a fever, you have to know when the most recent antibiotics were started. It makes a big difference if they were started 6 hours ago or 4 days ago. And what do you have to have when you call? Well, a chart, please, not just the Cardex, and have any recent lab and x-rays. Please review the orders from that day in case asked, or you may actually have an answer to some of your questions. You need to have the current vital signs. You need to have the MD review because that's the set of vital signs from the last several days, which is very helpful. And if possible, try to get the last office note in the chart from MD Network, and the care coordinators can know how to do that, although I'm not sure at night if somebody has access. Now think the problem through. Let us know what you think, realize we might disagree. And I have to be honest about it, is that some nurses are more experienced than others, and we know that, so that's going to matter, but we still need to hear what your assessment is, and that's extremely important. And what is your assessment and plan? And doctors react to this differently. Some might think you're arrogant if you make a suggestion. and others welcome it. And all I can say is sorry about that difference in the way doctors think about this. So, in summary, get the orders and read them back. Find out if you should call back for specific reasons. Please remember that doctors have to also work the next day. They don't work just night shifts. And to separate absolute urgencies, especially in the early morning, from those that can wait for rounds. For instance, if potassium is 3, it's generally not a very urgent problem. It certainly needs to be addressed in the morning, but when it comes back at 3 in the morning, that's not exactly a serious problem. Now, I realize that some laboratory they mark as critical, and therefore it demands that you call it, but use some judgment here in terms of this. And especially, obviously, platelet counts of 12,000 might be critical to the lab, but are not necessarily something we're going to address at 3 in the morning. And in communicating on the floor, we also want to look at that in terms of similar problems. It would be great if nurses could be available when we see the patient. I think the current mechanism of rounding on the patients frequently, pep rounds, and checking out with each other when you change shifts is wonderful, and I think that's really helped. Make sure the same process of knowledge, or a diagnosis, treatment, lab, etc. is in your mind while caring for the patient. And please avoid what I call hit and run, which is running up to the doc on round, say something you need about another patient and run away. That can be really distracting and may not get the job done. And I think it's important that you convey this to the nurse coordinator or leave just a note on the front of the chart that we need to address. In any case, communication is wonderful. I hope this slideshow was a method of communication. And always, as always, if you have any questions, don't hesitate to let us know. Thanks very much.